Do you have a lavalier?
Yeah, perfect. Can you hear me okay? All right. Well, so the funny part is when I started in this business 4 years ago, I'd go out and make the presentation about telemedicine and be real passionate about it. And the first line back usually was, "Is that legal? Can you do that?" And today, it's, well, that's a no-brainer. So it's amazing to watch in a short period of time how this business has evolved. So I'm going to tell you a little bit about Teladoc, the company, because we're probably relatively new since we acquired Consultadoctor, so you're probably more familiar with Consultadoctor than Teladoc, maybe in some cases. A little bit about how the, kind of what's going on in the marketplace, some of the how the member experience, and some of the differences with Teladoc versus competitors and what have you. So, and then I'll try to wrap that up pretty quick so I can leave time for your questions at the end. So let me jump ahead here. So just a little bit about the company. Our focus is quality. Quality is what we live and breathe, and because this is all about patient safety at the end of the day. There's a lot of bells and whistles on websites and a lot of cool features and functions and things like that, but at the end of the day, you know, I get extreme sometimes and say if somebody screws up, somebody potentially dies, right? So this is about patient safety. It's medical care being delivered remotely. So you want to make sure you've got the best doctor, quality QA programs, what have you. So I'm going to walk through some of the things we do as a company that are a bit different than our industry. This says, you know, we're the first and largest. My joke is we're the tallest pygmy right now. So we're the biggest in a small industry, but growing fast. So you're well aware of, and we've heard a number of speakers talk about the various different things going on in the healthcare marketplace today. Shortage of primary care physicians. We're shifting costs to members. I would say before this conference, I would say you're shifting costs to members unless you're with Cypress, because obviously with the trends you guys are seeing, that's not a lever you have to pull right now, which is fantastic. By the way, I'm taking the packet back to my benefits team and saying, why aren't we here? Because it's amazing the things you guys are doing. You know, we're expanding coverage, so we're going to add 30 million roughly people into the system that didn't have coverage previous, and with no new doctors. There's a lot of misuse of the ER. I consistently see reports that are saying upwards of 45, 50% unnecessary use of the ER for those things, kind of things that we can treat remotely. You know, and as providers, you see the provider risk arrangements, accountable care organizations. I even read an article the other day in the Wall Street where doctors are starting to drop out of the exchanges because the reimbursement rates are so low. So we're not fixing this problem anytime soon. What can we be used for? The basic episodic events that happen every day to all of us. It's you know, those things that you often know what you've got. You've seen it before, right? We're familiar. You know, as parents, we all kept the little bottle of ampicillin or amoxicillin in the refrigerator, right? Because we knew when the kid had the ear infection, and all we needed was the prescription. But basically, Teladoc is there and available 24/7, 365. It's access to a primary care board-certified physician that's often resident and definitely licensed in the state that you're in at the time you need a consultation. I'll walk through the member experience here in a little bit so you can kind of see how the process works. But if the doctor goes through the process with you and determines that you need a prescription, the doctor can then call a prescription into your pharmacy. It's done electronically through SureScript, so it's waiting there for you within an hour, and you're available to pick it up. So we don't write any DEA regulated medications, so don't call us for the Oxycontin, the Percocets, you know, that kind of stuff. We get those calls, but we can't help. And we're very focused on the overuse of antibiotics. That's a big problem in the country, and we have a lot of programs in place, both on the member side and on the physician side, to try to control that, monitor that. We look at that through our QA process every month when we review consultations to make sure we're not adding to the problem. I used to be able to say we're in all 50 states. We're in 49 states now. Idaho is the only state that we're not in currently. We had to pull out Idaho about a month and a half, 2 months ago. The medical board there was targeting our physicians and actually every telemedicine provider's physicians. Medical boards don't have control of our company, but they control the physician licenses, and so they start targeting the doctors and putting the doctors at risk. So we said, hey, back off on our doctors, we'll back out of the state. We're now going through a legislative process in Idaho where we're lobbying the governor and legislature to make a change there and affect them. We're a very aggressive as a company in our lobbying efforts and our focus to try to make sure that we are compliant in all states, and that anywhere we're seeing pushback and changes in regulations, that we're effective. We actually are a board member of the Alliance for Connected Care, which is a Washington, D.C. lobbying group that has been formed by the industry. It's Senator Trent Lott and Tom Daschle are leading the efforts as far as lobbying around the country for federal changes to Medicare and Medicaid telemedicine regulations, which will then help offset state regs as well. I love this slide because I always, when I'm at review time, I always go to my boss. It says, Mike joined here. So it doesn't help me with raises for some reason, but anyways, I try. So rapid adoption, as you can imagine, this is our stats, but this is industry stats, I mean, as well. The industry is seeing very, very good growth and very rapid growth. Like I said, this is becoming more mainstream than I expected, faster than I expected, but you'll see why with the satisfaction we're seeing from members and what have you. We've been fortunate to be recognized by some good organizations. Our CEO recognized by Goldman Sachs, one of the top 100 most intriguing entrepreneurs. My personal favorite is Fast Company, one of the most innovative companies in the world, which we're only one country. I don't know how it's like the World Series, right? I don't know how you win the World Series when you're only in the U.S., but hey, we'll take it. And then RAND, I'm going to talk about a little bit, is there's some great emerging third-party data on the savings that are coming out of telemedicine. This was a study that was done on Teladoc and the CalPERS population that we manage in California. And so I'll share some of that data. It's really interesting to see how this is starting to evolve. This is what we call the billboard slide. So just some stats on our company. Huge member satisfaction, no surprise. Care is finally coming to you. You're not having to go to it. And it's 24/7, 365. We see very strong utilization across the employer book of business, so about 10.6% in the first year on average. It varies based on populations. High turnover is a problem, obviously, but we're seeing strong adoption and growing adoption. I liken our industry to the minute clinics and the take care clinics 10 years ago. When you got sick and it was the weekend, you said, I'll wait till Monday and I'll see my doctor. You didn't think about going to the minute clinic, even though it was probably one not too far away. Now I call it the 120-minute clinic because everybody goes there, right? Because it's well recognized and used. A doctor in your pocket will be the same thing eventually. You can pick up your phone and use it anytime. 91% resolution rate, and we've done a lot of claim data validation. We're not actually seeing people going to get care after a consult with us, so we're not adding to the cost problem. And so I'll share some more of that data with you in a minute. We're going to do about 250,000 consults this year alone. We did 25,000 consultations in January as a company. I saw a great email that came out that was a recruiting email for another company who was trying to get doctors to join, and the stat was, and we've done 600 consults this month. And I'm like, wow, that's pretty good. We're doing 1,000 consults a day in some cases. So, but we were doing 1,000 consults a month 4 years ago. So it's it's where you got to start. Very high client retention rate, as you can imagine. We've never, as knock on wood, never have had a malpractice claim in the history of the company. We provide the malpractice insurance for the physicians so that all our employer customers are covered. There's not any liability when they put a service like this in. We have a 1-hour guarantee, so if you request a consultation, we guarantee that consult will be delivered in an hour. Our average right now is about 17 minutes when you request a consult at the time a doctor's calling you back. We have well north of 2,000 clients today. As I mentioned, clinical focus and quality overall is a big stamp for us. We are the only company in the industry that has gone through NCQA and received NCQA certification of a credentialing process. That's a year-long process, $100,000 expenditure, but we felt it was that important to make sure that we were getting the best stamps of approval, if you will, especially as a young industry and a new industry. You want to make sure that it had the validation and review of a company as high quality as NCQA. We only use board-certified physicians, both primary care and pediatricians, so available in all states, 49 states. We've made a process that if you request a consult from us, we're going to steer that consult to resident doctors in the state first for the first about 5 minutes. They will get that consult request initially, and then if they don't pick it up in that period of time, we'll open it up to doctors that are licensed in the state but may not be resident in the state, because we feel it's important for us to be able to sit in front of any medical board and say, we're keeping the money at home. These are your members that are actually getting these consultations, because these are independent practicing physicians that are in our network and that we work with. So it's one of the things that we think is really important. We see competitors that are building call centers in Boston, you know, so if you're in Mississippi and you're getting a Boston accent, that's probably not going to go over real well when you're going through that consultation. We want local docs in the local community delivering the care. We have the highest quality oversight of the industry, so we review 10% of all consultations. So in January, we're reviewing 2,500 consultations with our quality oversight committee, which is physicians, nurses going through all of those charts to make sure being documented properly, proper care was delivered, we're not overprescribing antibiotics, you know, all the things. We have developed about 110 telehealth standards of care that are available to our doctors on the site while they're in the middle of a consultation if they want to review the standards, and we review them against those standards as we go through the quality process. As I mentioned, 91% resolution. So when someone requests a consultation, we do a follow-up survey after every consultation and ask, did we completely resolve your issue? 91% of the time they say yes, and we've also gone through and looked at claims data both 7 days and 2 weeks after a consultation to see if there's any care for a similar or same diagnosis, and we've been able to validate that number almost exactly. Of the 9% that don't get resolved, about 4% need to be referred out. Not quite an emergency, but it's probably something more complex, or the doctor's not comfortable making a diagnosis because he's hearing that there's something more going on there. 2% may be out of scope. You know, if somebody has a cut or something like that, that's not something that we can treat, as an example. I talked about the seeking the pain pills, the 2% about seeking certain meds that we're just not going to write. And about 1% we actually send to the ER. We'll get those calls once, well, I think I've got indigestion, but it's radiating down my left arm. Like, wait a minute. And so the doctors have a whole process to alert and get someone to the ER quickly. So I'm going to talk a little bit about the emerging third-party research around savings that we're generating a lot of and actually are pushing to try to make sure that this industry has third-party validation. It's not just take my word for it. So the RAND study, RAND did a study on Teladoc's CalPERS population that we service through Blue Shield California, about 350,000 members. They primarily designed it as an ER reduction program because in California there are a number of providers that are capitated that are supposed to be there to take care of routine care and things like that. So we heavily promoted ER reduction. This is one of the quotes that came out of the study. I want to back up a step. When I first got to Teladoc, we were using this model, ROI model that the former founder of the company had developed, and in it had an average ER cost for the top conditions we treat of about $750. Urgent care was about $150, primary care $120, what have you, and it seemed reasonable. All right, makes sense. We never trended it forward. We never updated the number, anything like that. We finally said, well, we got to go outside and get an actuary to look at the data, build us a model, certify that model that we can use in the industry so it's not just us saying this. So we hired an outside actuary. We gave them about 800,000 members worth of data, and we said, what's the ER cost for the top 50 conditions we treat? A weighted average. And so they went out, and I'm thinking, yeah, I hope they validate the 750. That would be terrible. They came back at 500 or something like that. What's going to do to our ROI? Well, fortunately, they came back at $1,500 as the average ER cost for the top 50 conditions we treat because we weren't capturing the lab, the radiology, all the extra stuff that happens when you walk in that ER. Urgent care was about the same, 150 to 200. Primary care was about 140. So, but the ER number was big, and it was amazing to us that it was that high. What was really interesting, and the folks at Cypress know this every day, upcoding is pervasive. Right? We were looking at, everybody says to us, when I meet with a health plan, I'll get in front of their medical economics group and they're going, well, you can't treat anything more than a level 1 or level 2 ER visit. That's a level 3 severity? No way. Level 4, that's a car crash or something, right? You can't treat a level 5. Well, come to find out, it has nothing to do with severity of the patient. It's time spent by the doctor. And so only 5% of the claims in that entire data set were level 1 ER. They're always level 2 at least, and 3 and 4 often. And so I'll talk about a third study that we're doing right now that's come back and validated that exact situation. So what the RAND study found, so phase 2, RAND study found that when you go to ER or an urgent care or primary care, if you go to the ER, let me find the numbers up here. If you go to the ER, 20% of the time you're going to have a follow-up visit with the primary care because what do they tell you when you walk out? Hey, by the way, make an appointment with your primary care doc and go see your doc. Well, for a sinus infection, not really necessary. So not only is the episode cost expensive, there's 20% of the time another follow-up visit that happens in addition to that. If you go to your primary care physician, 13% of the time they're having you come back and see them again just to make sure you're fine. And with Teladoc, it was 6. So it was, so the savings is not only of the episode avoidance at the beginning, but now there's this extra care that's being delivered that may be unnecessary as well. A couple other interesting stats. So what RAND found is that if you look at the Minute Clinic and the Take Care clinics, their top 3 categories of diagnosis represent 72% of their business. For Teladoc, it was 52%. We treat a much broader array of conditions than what's being treated in those walk-in clinics. So we've got a better opportunity to address more than what is showing up in the urgent care clinics. What I thought was interesting is 25% of the visits that we saw were people that didn't use the medical system at all the year prior. So they don't have a primary care physician relationship established. They're not seeking care anywhere else. So this was a great first place that they went. Actually, I'm going to back up here. So the next study we are funding right now is we're working with a gentleman by the name of Arnie Milstein, who used to be a top consultant at Mercer and is now at Stanford University, and Nitish Chowdhury, who is a professor at Harvard Medical School, and they are doing a study for us. We gave them the Renner Center data, which is about 20,000+ members. We've had that company for 3 years now, been servicing their employees. They're seeing about 40 to 50% utilization of our service. And so we gave the data to Nitish, and he was a naysayer. He'll tell you he was a naysayer when he got the data, so there's no savings here. There's no way. And he did a lot of work around the Minute Clinic and what have you. So interesting what he found. One of the questions we ask before every consultation is, where would you have gone if you didn't have access to our service? And the options are emergency room, primary care, urgent care, specialist, or do nothing. About 8% of the time across our book of business, they say, oh, I would have gone to the emergency room. Like, okay, so that's how we actually show a value proposition back to our clients. So 8% of the time your members said they would have gone here, that would have been a $1,500 cost. It's now a $40 cost. The savings is X, right? We take the member at their word. Nitish gets into the data, does a like cohort matches of disease prevalence, age, sex, everything else. 25% of the time people are going to the ER in the actual data versus 8% of the time they tell us on our surveys. So not only are we underclubbing the value proposition on how many people are going to ER, before we were underclubbing on the cost. So this is really bringing out some really interesting analysis. Sum this all up, it looks like, putting everything together, the average savings per consultation across when you have a Teladoc consultation is about $700 each. You're paying $40 and you're saving $700 net, roughly. That is significant savings beyond anything we thought. And now that we've watched the evolution and it's been done by a third party, we'll be bringing out new models to help validate that, report that to clients. But this service is really turning into something that has a big impact on claim costs, more so than I even expected being in the industry. I'll talk a little bit about the member experience, just if you've never used the service before or are familiar with the service. Very easy to use. When you sign up, you're going to get a welcome kit sent to your household. It's going to give you instructions on how to log in. You can either download the mobile app, you can go to the website, you can call Teladoc, 1-800-TELEDOC, and do everything by phone. Your whole health history, you have to do anything on a computer if you don't want to. But you'll go online, you complete a brief health history, just like that clipboard you fill out in a new physician's office. So you check, what you have, what your allergies are, medications you take, family history, that sort of thing. Very quick process. When you need a consultation, you can, again, pull up your mobile app. You can request a consultation through the mobile app. You can request a phone or video consultation. One of the new features is you can now schedule a phone consultation. So for those hourly workers that come in at 8 o'clock, they're not feeling well, and they've got a break at 10:30, they can schedule a 10:30 consult. So when they have their break, they can have their consultation right then and there. So that's a new feature we just added recently. Video consultations were always a scheduled appointment because we want to make sure the doctor's ready, the patient's ready, what have you. We just added recently as well dermatology and behavioral health. Now we're doing that through our primary care network at this point. So behavioral health is really episodic, right? I've got an event, I want to talk to somebody, I may need a medication to help, and there are medications that are not DEA regulated that can be written for that sort of thing. Dermatology is through our primary care network as well. It has to be a video consultation. You can take a photo and upload it right into your health record while you're on the consultation so the doctor can see what's going on. With the high-def cameras we have now on our phones, that makes it really easy. So any one of these conditions can be treated, obviously, but you request that consultation. If it's a phone consultation and you're not scheduling, you just want to call back, when you're done with the consultation, you go about your business, and on average, in 17 minutes, the doctor's calling you back on your phone, and you'll start the process. As I mentioned, you can access through multiple means, phone, web, on your computer, what have you. We talked about prescriptions, electronic prescriptions through SureScripts, no DEA. And one big piece is we are not a replacement for the PCP. So a couple things we do. Before you have a consultation with us, we're going to ask you a question. Would you like us to send a record of this consult to your primary care physician? And on every consult, we're asking that question. If you don't have one listed, we'll ask you to put the information for the primary care physician in, and we'll send that consultation history to the doctor, usually a secure fax. That's kind of the mode today, but we can send electronic health record if the doctor can receive electronic health record. But it's important because we don't want to be your primary care relationship. You need to have a face-to-face established primary care physician relationship. One thing we also do as far as just quality oversight and patient safety is if you contact us 3 times in 90 days for a same or similar diagnosis, we're going to start talking to you about the importance of seeing your primary care doctor because there may be something more going on there. You know, that's if you're having that kind of repeat that quickly, there may be a lot more going on. 8 times in a year, worst case scenario, we may stop you from using the service until you've proven that you've seen a primary care doctor because there's probably something more going on. Now, we take in everything into account. If you're in a rural area and access to a doctor is just difficult and you have to use us just because of where you are, that's fine. You know, and we'll take that into account when we get engaged with members about why are they using us so frequently and do they understand the importance of establishing that primary care physician relationship. At the end of a consultation, the doctor can send a secure message to a secure message site on your portal. He can send additional information about the condition you just discussed, so anything about a sinus infection, have you pre-printed materials. He can send you discharge plan. So here, as I mentioned on the call, if you're not feeling better in 72 hours, please do X, right? Those kind of things. The member has 72 hours to ask questions back to the doctor during that period of time to see if they doc, I didn't understand this, or hey, this just happened, or I'm not getting better, what should I do? So they can actually contact the doctor back with questions to make sure that we're closing that gap and making sure the patient has been resolved, the issue's been resolved, and they're moving on with getting better. So I mentioned mobile. We talk about mobile specifically because not all mobile apps are built the same. So I'll give you an example. So I was in a meeting with a health plan, and they had used one of my competitors on a pilot and decided to get rid of them because of their mobile app. Their mobile app only allowed you to do a consult in Wi-Fi or 4G. And in their part of the country, 4G just was not that prevalent. We took a little longer building our mobile app, but you can do a mobile app in 4G, 3G, Wi-Fi. You can walk between the 3 and not lose the consultation. So the idea is, because we're not all in a 4G area all the time, and you may be walking around and be in 4G at one moment and 3G the next. So we've built ours, the picture will pixelate a little bit, but you will not lose that connection with the doctor. And so that's been a problem for some of our competitors who haven't really invested the money and time in really building this out. And it's a key feature that you don't think about until you got it. And then you're on that 4G connection, you walk over here and you've lost the consultation, and now how do you get back to that doctor and get that whole process started again? Today's measurement of savings looks like this. I've mentioned most of this already. So on the left is the response to the question, where would you have gone if you didn't have access to our service? And then on the right is the average savings per episode. So $14.77 in the ER versus $40, urgent care $160, specialist $196, primary care $131. Down below that weighted average, that generates about $198 in savings per consultation today. This is not factoring in the Harvard data yet. One more point on the Harvard data, so the next step is we're actually providing the data from the Home Depot, 126,000 members that we have, or employees that we have covered in all their lives, so they're gonna do the whole thing all over again using a much bigger national data set. So once we get those two done, then we'll have a white paper that we can use to help validate. We know there's savings when an employee uses this and doesn't miss work, or they don't have to stay home because there's a child that's sick and they weren't able to get care over the weekend or what have you. So we estimate, CDC says we spend about 4 hours twice a year getting care, leaving work, driving to the appointment, having the appointment, coming back to stop at the pharmacy and then back to work. And so we will plug in estimated hourly wage here for each customer to figure out roughly what productivity. Productivity is very tough to measure, as we all know, but it's there, and so we want to make sure our customers don't lose that aspect of the savings, because we all report to a CFO somewhere, right, when we have to talk about this stuff. So that net is about $285 in savings per consultation today. A lot of conversation about utilization in this space, and it ranges widely. So here are some samples of various different industries and different clients in those industries when they started with us and the utilization they're seeing across their customer base. And this is measured all consults divided by the number of employees. All right, so we bill on a per employee basis usually, and so very strong utilization. Break even is about 3%, 4% will get you to break even in year one. So it doesn't take a lot of utilization to get to break even, but these customers are seeing significant returns on their investment. Again, not including the Harvard data, which would say this is even greater returns. So that's kind of the end of my presentation. Really wanted to spend time answering your questions as we could. Yeah. Oh, good.
Holly's no longer in charge of the microphones, so now Drew's going to be in charge.
Can you hear me?
Yep.
Is there a minimum size group that you would accept, and then do you have any of the communications multilingual?
No minimum size. We have groups down to 2 lives, and we have both English and Spanish communication materials. Absolutely.
And Mike, are the conditions expected to expand? So are you going to be growing on those conditions? And are there certain conditions that if a group had specific conditions going on, could those be added?
We haven't. So we are definitely going through clinical expansion. So we'll be expanding. One of the other features, a recent partnership we just developed was with a company called HealthSpot. HealthSpot's a medical kiosk that you walk inside. It's got an otoscope, dermoscope, stethoscope, pulse ox, blood pressure, height, weight, and it's a virtual interaction with a doctor. It's great as a replacement to an on-site clinic, and that gives us great clinical expansion because of all that extra data. You can look in the ear now, you can look in the throat, what have you. But we are definitely moving clinical expansion. We're having discussions now about an OC-Health program, to try to be a triage service, that first call, to make sure that we're getting people to the right place, because you can treat back pain and things with high-dose Tylenol and what have you. So definitely, your second part of your question, I think I missed it. Clinical expansion, and then there was... specific. Yeah, we have not done client-specific. We are trying to build across the book of business. It's just so difficult to do this here and not there, especially when you've got contracted physicians who are used to just operating in a certain way. So we're trying to we're asking our clients all the time, what would you like us to expand to, and what else could we do? And so we're trying to add those as we go. Yeah, but the dermatology and behavioral health were the first two to kind of expand that opportunity.
So as an employer, the cost of this, do you feed that data back to Cypress? And does that apply to deductibles and co-pays, co-insurances, or are employers offering it as a free service because we're saving $700 and some per call?
So that's a great question. There's 2 ways to offer the program. There's what's called a consults included model, which has been the standard model that I think our industry started to develop early, which was it's a PEPM fee and everything's covered in that PEPM fee. There's no extra consult cost. I would tell you with where utilization is going to go and where we hope to go and try to drive utilization, there's another model which is a separate PEPM fee and then a $40 consult cost that we can integrate into claims and send in a claim. And then you can decide what you want the member to cover and what you want to cover. So if you want if you're in a high deductible health plan, for example, maybe the member covers all $40. We see clients like Rent-A-Center offered at $5, and they're seeing, as a retailer, seeing 9–10% utilization. Where even with high turnover. We see a lot. Rent-A-Center offers it for free. It's a zero copay, but we file a claim with their insurance company or their administrator for the $40, and they decide it's just important for us to cover. So
right, and we can do it either way. It doesn't matter to us.
Right.
Most of our, if not all, correct me if I'm wrong, anybody who's out there, I think everyone has it with a $0 copay for the employee.
Right. Yeah, it's really personal preference. Sure. What's your goal?
John before back there. Oh, I'm sorry.
Who are these doctors?
Great question.
Are they moonlighting or what?
Yeah,
I'm one of them, actually.
So the doctors are about 40% of our network are ER physicians that do primary care. So they're 4 days on, 3 days off, and so they do this in their off time. A good chunk of the network are practicing physicians. These are actually practicing doctors. They're not in a call center, not employees at Teladoc. This is not their full-time job. Now, we do have a couple of doctors who have started to make this their full-time job. We have one physician who he's put all his kids through college, basically. He was doing 1,000 consults a a month and generating for him about $20,000 to $25,000 a month in income. You know, plus no overhead, no staff, no malpractice insurance. You know, it's a much better deal for them. So,
we're on your program, and I've been having trouble getting the employees to really get going on it. But you just hit a hot note with me. We've given every one of our employees an iPad. Every employee has an iPad, and that app, I'm assuming, could be uploaded to the iPad.
Absolutely.
So if we were to pull our employees all together and say, bring your iPad, we're going to sit down, we upload the app, and then we go online with somebody and show what it would be like, I think that would be really, really good incentive to get it going.
Happy to help with that. Yeah, absolutely. Yep, absolutely. And one thing on utilization driving, we see 4 times the utilization on a zero copay than we do on a $40 copay. As you can imagine, no surprise. And so, and with that zero copay, the customer gets 2.5 times more ROI, even with the extra cost of the consult included, because of that extra utilization that they're getting. So it's worth a low copay to no copay model because it drives adoption, utilization, and what have you. Now,
I just want to be clear to all of the Cypress employees that we're not buying you iPads.
I apologize if I missed this, but how do you verify that it's actually a plan participant or an eligible participant calling?
Yeah, so we collect an eligibility file on whatever frequency, monthly normally, and load that into our system. So they have to, when they come ping our system, we'll verify name, birthday, and a variety of different steps to make sure they are who they are. The doctor will do that as well. When the doctor has a consult, make sure they're talking to the patient who they say they are for care. Yeah. Other question?
All right. Oh, go on.
Does any of this information ever go back to the patient's attending physician?
Yes. So we ask before every consultation, would you like us to send a copy of this record to your doctor? And if they say yes, then we will get that to the doctor. I would tell you a lot of people don't because it's a sinus infection and they don't really care. But we offer it for every consult. If you want it to get to your primary care doctor, because we don't want to break up that continuity of care. We'd like that to be in the patient's record with their primary care doctor. Yeah. Other questions?
All right. Are we done? All right.
All right.
Awesome.
Thank you very
Thanks,
much.
Mike. Appreciate it.